Hello and welcome to Internal Medicine, where we talk about ER topics and we talk about internal medicine topics. Today we're going to be doing something a little bit different, where we're going to be talking about some of the updated changes that are coming down from the ACGME regarding emergency medicine program requirements. Some of this stuff has made pretty big news already. These are not finalized by any means, but they're supposed to go into effect in 2027. So I've read through the ACGME guidelines. I've read through them several times in the past, had them virtually memorized, and they went through and changed everything. So what I'm going to point out today is some of the things that I thought were interesting about changes, what this might mean for programs, and maybe how to adapt. So starting with the first big change that we've seen is they're moving to a 4-year program. So this is kind of what caught everybody's attention. 4-year program being a 48-month rotation, minimum of 16 residents now, which is down from 18. 124 weeks are supposed to be in emergency medicine, specifically 62 weeks at primary site. And I'll get to the difference between primary site versus other sites. So 124 weeks of a 4-year experience. So 4 years is 208 weeks. 124 weeks of that ends up being about 59.6%. So no big change there. The previous guideline said they needed 60% of EM time. But the interesting thing is the 62 weeks at the primary site, which only ends up being about 15.5 months over 4 years. So that seems to allow for a lot of flexibility for programs to kind of do what they want between working between primary sites or secondary sites or external rotations. Another proposed change is must utilize one high resource and one low resource emergency room. So this is another big change. So a high resource emergency department is defined as having readily available tertiary resources, diagnostic, therapeutic, interventional capabilities, and consultants, and rarely transfers patients for higher level of care. At least 4 weeks must be spent at this location. A low-resource emergency department has limited diagnostic, therapeutic, interventional capabilities, consultants, and specialty services, and may offer transfer for patients for higher level of care. And greater than 4 weeks must be spent, a minimum of 4 weeks must be spent at a low-resource center. So this is another big change. So kind of what they're talking about here, low-resource centers might be more like freestanding emergency rooms. They might be low-access ERs, community, rural-based, just places that require transfer. So some of the other institutional requirements from low resource centers that they also need the same resources that the larger center is going to need, and at least in the sense of workspace for faculty members, workspace for residents. So it has to have the same type of resources that you would normally have learners and trainers in, at least for their own comfort and education. And another emergency room requirement for each one of these places, the low resource centers, is that they need to have if they don't have certain consultation services, they need to have written protocols and provisions for how they obtain these services elsewhere. So this is another requirement of all primary sites, but now they're requiring it at secondary sites as well. Moving along to one of the more complicated things I saw, mostly because it involves a whole bunch of math, is the 3,000 annual patient visits per approved resident. So let's talk about what that means. So to do that, we're going to have to do a whole bunch of math. So starting with, let's take a hypothetical program, for example. So let's take a 3-year program that currently has 18 residents in it. So during their PGY 1 year, they're going to do 7 months of EM. PGY 2, they'll do 8 months of EM. And then PGY 3 year, they'll do 7 months. So adding that up, that ends up being 88 weeks in total. So if we take this 32,000 visits a year for this center, we divide it by 52 weeks, we get about 615 patients per week visits. We times that by 88 weeks of emergency medicine experience they have over their 3 years, and we come out with 54,153. So that's their access to patients that they're going to see over those 3 years. So we take that by the amount of residents that we have. So if this place has 18 residents, meaning it trains 6 per year, we take the 54,000. In 3 years, we divide it by the 18 residents, and we come up with just barely over the 3,000. I thought this was unusual the way they named this, because they named it 3,000 annual patient visits per approved resident. But really what the math they're having you do is more related to access that patients, or that each resident has to patients over the course of their entire residency rather than annual. So I thought that was kind of a confusing number. So I feel like if they wanted to do it by year, this 3,008 should also be divided by 3, and then that's how many actual patients they're having per year. But the sample calculation that the ACGME provided only had it doing it this way. So the total amount of patients that they have access to by their emergency medicine rotations over the course of the residency, and then dividing that by the total number of residents that you have. So That's the sample calculation I came up with for this hypothetical residency with 18 residents and 32,000 annual patient visits per year. So the questions I have about this are things like in the old guidelines when they talked about what could be counted as an EM experience, they also included things like pediatric emergency medicine rotations. They also counted emergency ultrasound rotations. So they haven't made any determination, it looks like, if these can be factored into these numbers. The other thing is I imagine vacation time will be deterred from this as it decreased from the total amount of emergency medicine experience they had previously. So you would also need to, if you were exclusively doing vacation time during your rotations, then those weeks would also get minused. All right, let's hypothetically do some additional math and talk about what's entailed in turning a 3-year residency into a 4-year residency. So this would be, if you're accepting 6 trainers per year, this would be 24 residents total over 4 years. So hypothetically, let's have them do an extra 8 months of emergency medicine in their PGY 4th year. So this ends up being 120 weeks total of emergency medicine. So hypothetically, in the same emergency room setting where they have 32,000 visits per year, and we take the 120 weeks of the 615 patients per week, then we end up with 73,836 patients that the resident would have access to over the 4 years with their EM rotations. So if we divide that 73,836 patients divided by the 24 residents, then we would come up with 7,076 patients per year. So simply holding across the same experience that the resident would have had for the first 3 years, as long as you were maintaining compliance, seems like it maintains compliance here. Again, factoring in things like the vacation months and pediatric EM experiences and EM ultrasound month to see if they count, because your numbers would go slightly up or down. But it looks like you wouldn't have much trouble maintaining compliance with that. Maybe you'd have to add one other EM month experience. So now let's talk about that low acuity or low resource emergency room situation. So let's say we're going to add an experience at like a freestanding emergency room that sees about 23,000 patients per year. Let's say they're going to do 1 month rotation there, which is the minimum. Let's say we'll do 1 month, actually a year at this site. So that ends up being 16 weeks over 4 years. So 23,000 patients a year divided by 52 weeks ends up being, in this setting, instead of 615, this resident would have access to 442 patients per week. So what this does is this changes the total access that the resident's going to have, the total access of patients that they're going to have over the course of their experience. So doing some quick math, so if we normally had 120 weeks, but now we're adding in this low resource center, and we're minusing 16 weeks by that, at the 16 weeks of experience, the resident would have 7,000 approximately visits, and then that 120 weeks now just got decreased. So now they would only have access to 63,900 patients about. So this is how you get your total. Now the resident over the 4 years would have access to 71,067 patients over the 4 years. And then now if we divide that number by 24, we would end up getting a lot lower of a number. So now we've got 2,961 patients per resident, which doesn't meet the threshold. So my point out of all of this is that lower acuity emergency rooms, they actually detract from the total patient access that each resident has. So some of the people that have emailed me, faculty members and residents alike, all saying like, well, great, we can add on all these other sites, and that just kind of gets dumped into a total number. Well, it doesn't. The problem is it gets weighted by the experience and the amount of time that each resident has at these sites. One of the other things they're tracking at the lower resource centers is critical care volume. So these numbers get aggregated. So again, if you're kind of close to the minimum for critical care numbers, sending residents to lower access or lower resource centers isn't going to be helpful for kind of goosing those numbers. The other thing is faculty at low acuity emergency rooms, not ABEM or AOBEM certified, will have their time reduced from the 124 weeks of core emergency medicine that each resident's required. So what they're saying with that is they realize that maybe freestanding emergency rooms aren't necessarily always staffed by board-certified emergency room physicians. They say that's okay, but it's going to detract from the 124-week experience. So my personal take is that really they should have access to an EM supervising physician. Otherwise, you have to do a lot more math to calculate out exactly who they're spending their time with and how that detracts from their overall experience. When talking about the critical care numbers, hopefully we can still use billing code numbers for this. Otherwise, tracking all of these patients that are going to get transferred, are they going to be transferred to an ICU? Are they going to be transferred to emergent surgery? This is also something you would have to track. And if you have a low acuity center, sometimes it's difficult to track exactly where those people are going if you're shipping them out, if they're just going to a larger hospital, because a lot of times you just ship ER to ER. So you don't necessarily know if they end up getting admitted to a step-down ICU, maybe they got admitted to general medical floor, maybe they got seen by a specialty service and got sent home, but how would you track all that? Getting back to some of those critical care numbers I was talking about, so a new change is that the aggregate annual volume of critical care patients at a primary site and participating emergency departments, clinical sites must total at least 120 critical care patients per approved resident position for the program. So again, there's a lot of math that goes into this, but this is tracking patients that get admitted to ICUs, get admitted to emergent surgery, they get admitted to step-down units, which is great now because that's not something they had in their language before. But also are discharged to the morgue also counts as critical care volume. The previous guidelines talked about calculating your critical care volume based on patients that moved to any of those sites I just previously listed, but it did it as an aggregate percentage over your total volume. And the previous guideline requirement, I think, was a minimum of 1,200 critical care volumes per year, or 3% of your volume had to be critical care. So let's talk about some changes to faculty members. Now they're talking about the faculty members having a background and focused experience in things like patient safety, quality improvement, scholarship, ultrasound, medical education, including simulation, and then actively engaged in the development, implementation, and assessment of their specific areas of curricular content. So more diversification, I imagine, in faculty members, that you have to have somebody maybe appointed who's your ultrasound guru or quality improvement guru, and that they're changes to your curriculum, as well as monitoring how residents are doing and output of any of these areas. Another change in faculty members is they must have appropriate qualifications. So faculty members must have appropriate qualifications in their field and hold appropriate institutional appointments. That seems vague. One of the things I did notice was what was crossed out of that must be board eligible. It was another qualification for a supervising faculty member, and that seems to have gone away. So if you have a new or graduated resident who's maybe joining your faculty and everything and very excited to start training residents, it doesn't seem like they can anymore, at least until they've passed a qualifying exam. So that might deter people going into education immediately out of residency, which can be a good or bad thing depending on how you look at it. But as far as when we're trying to recruit more people into medical education, the option to do it right out of residency would be nice. But I guess this is more lighting a fire for them to pass their qualifying exams immediately out of residency. Another specific change is that the assistant or associate program director must be a core faculty member, which is something that was old, but must be clinically active in emergency medicine. So not a big change that's there, but if you had an APD that was, retired or something, or maybe was just showing up at didactics, they have to be more clinically active now. All right, let's talk about some of the ACGME competency changes that are happening. So starting with patient care, they added some language about low acuity patients. The end of life stuff that got moved out of system-based practice as communications and now got added to patient care. So now residents have to demonstrate that they are competent in comfort care, end of life care, decision-making capacity, incorporating social determinants of health and societal impacts on health into patient evaluation and decision-making. Competencies in effective managing and dispositioning patients to facilitate efficient throughput and flow. Demonstrate competency in reassessing patients and adapting care plans to dynamic changes in patient condition. So how you can stipulate to some of this, some of it can be with didactic experiences you can point to where they've had education, maybe they've had simulated conversations with patient regarding comfort care. Maybe you've had flipped classroom end-of-life care discussions about how to manage hospice patients. Maybe you've had decisions about Foundations does stuff about specifically on decision-making capability. But the determinants of social health and societal impacts and health into patient evaluations and decision-making, I'm a little curious about how that will get implemented into a curriculum regarding patient care specifically, as well as competency in effectively managing dispositions of throughput and flow, how you demonstrate that. I imagine you could do something on evaluations for residents. We're talking about their ability to multitask, which is also one of the milestones anyway, but maybe you could demonstrate that they're being monitored or being talked to about their ability to manage patients from this specific point of view. Some procedural changes. So performing common procedures encountered in low acuity settings. So since they're going to go to low resource centers, they need to track procedures that they're doing there. Some of the language around resuscitation, and this was resuscitation or trauma patients, regarding neonatal patients, pediatric patients, as well as adults, that they need to act as a team leader, was new verbiage they used. They started including things like arthrocentesis, paracentesis to procedures. I imagine those will need to be tracked if you're not already tracking them. Pacing defined as transvenous as well as transcutaneous, which is great. I kind of assumed that from before, but they actually changed the language around to match it. Thoracostomy also includes pigtail catheters now. Great. I kind of assumed it did before, but I'm glad they included it in the language. Tracheostomy got included with cricothyrotomy, and reductions got defined as fractures or joints. So I imagine this is something when electronically residents are tracking their procedures that you would have to say if a reduction was joint or bone related. So talk about changes to practice-based learning. So residents must demonstrate all of the following. So competencies in adapting both their knowledge and their clinical care to shifting patterns of diseases and evolving scope of patient practice to meet the needs of their local and national communities. So I imagine you could cop to this by talking about more like modern stuff, epidemiology, recent outbreaks, patterns of violence kind of in your community. As long as patient or residents are being educated on those aspects, I don't see a problem with being able to maintain compliance with this. So identifying and effectively utilizing credible sources of information and current and emerging technologies to address knowledge gaps and achieving learning goals. I actually kind of like this one. So credible sources of information. So decreasing misinformation. So much nowadays, residents are just Googling what doses of a medication to give for something, or they'll look at the very first site that they Google when they're trying to answer a clinical question for themselves. So I think this is a good change. It highlights getting rid of misinformation as well as high quality resources when doing research or to educate yourself. We're already talking about doing some changes in our journal club, where we were talking about doing social media critique as well as critiquing online resources, things like WikiEM, actually looking at the resources, the works cited that they have for each of these recommendations they're making and investigating to see how true they are. So that already matches something I wanted to do anyway. Another thing for practice-based learning is identifying and mitigating their own biases and limitations. I imagine implicit bias training, if residencies aren't already doing it, should probably have that incorporated into their curriculum. Competency in utilizing feedback to improve effectiveness of teaching. So this could be, I imagine, stipulated to by if a resident gives a presentation talking about giving them feedback specifically on it, as well as maybe education about feedback itself. So we already do a lecture related to feedback in resident education. So I imagine that would maintain compliance, but if you're not already talking about feedback, how to give it, how to receive it, how to ask for more of it, then that probably should be something you implement in your curriculum. Interpersonal and communication skills. So they didn't make very many changes on this topic. They cleaned up a lot of the language. They talked about death disclosure, unexpected findings, and medical errors instead of just medical errors. This needed to be, I think, a real or simulated patient safety disclosure event. So I imagine talking about death disclosure, unexpected findings kind of all fall under the previous attestation that residencies were doing regarding medical errors. Some of the new verbiage they used was talking about obtaining informed consent and refusal, so that needs to be included in a curriculum. And then communicating effectively with law enforcement and regulatory agencies as serving as a mandatory reporter. So that one kind of gives me pause. I don't quite know off the top of my head how we've maintained compliance with that. So let's talk about some of the changes to system-based practice. So residents must demonstrate leading and coordinating the patient care team to optimize patient management and department flow, including the transfer of patients out of the department, understanding the role of emergency medicine physicians in the patient experience, and understanding the business and administration of emergency medicine practices. So I imagine the first point, you could probably change some survey questions as well as changing some of your goals and objectives in an emergency medicine rotation to make sure you're maintaining compliance with that. If you're having any kind of administrative meeting where you're talking about patient experience or Press-Ganey scores, I imagine you would maintain compliance with the second point. In the business and administration end of medicine, they are starting to require 2 weeks of admin required now, which I'll get to in a little bit. But if you have anything talking about billing and coding or RVU usage, or if you have really anything that relates to administration in the form of education, I imagine that's pretty easy to maintain compliance with. Now for more of the fun stuff, didactic changes. So education methods has to be based on evidence-based adult medical education theory. So it sounds like they're more just, they got rid of some old language. It sounds like they're just trying to use some more modern language with this. Evidence-based adult medical education theory is stuff that a lot of people are probably already doing. It's simulation medicine, it's flipped classrooms, it's mentoring and coaching, it's case-based as well as problem-based learning. So a lot of us are probably doing that anyway. The time requirements changed. No longer is it 5 hours per week of didactic time. Now it's 240 synchronous hours annually. So 240 hours annually ends up being, what's it, 52 weeks, so that's 4.6 hours per week. So the goal, I imagine, is to be a little bit more flexible about the weekly requirements. So I imagine you just need to hit that hour requirement. You don't necessarily have to meet every single week. So we had an issue this year where I think 2 of the didactic days fell on New Year's and fell on Christmas Day. It's kind of impractical to have didactics on that experience. So I think they're just kind of loosening the requirements to give you more flexibility about the frequency at which you have didactic sessions. As far as faculty attendance for these, all planned didactic experience must have faculty members in attendance. That changed from core faculty members. So any faculty member can host. A minimum of 50 hours of attendance per year for faculty members. That's changed from the 20% attendance from before. I think that probably adds up to about the same. Yeah, faculty must present at least 50% of didactics was the old verbiage for this, and now they said lead, which I kind of like better because if you're giving a resident an assignment, if you're giving them critiques on kind of how they're presenting information, what they did, you're leading didactics. I don't think you're necessarily presenting specifically at it. So I kind of like the looser language they added with that. Residents must attend 170 hours annually. That's not a big change because before they had to attend 70% of didactics. So that's pretty much 70% of the 170 hours of the 240 hours annually. So moving on to other curriculum changes, now they call them experiential curriculum changes. So they have these defined as structured activities and rotations, so kind of rotations to talk about. So this is a discrete, identifiable periods of time when residents are engaged in learning experiences depicted on the block diagram. Rotations can be described in weeks, calendar months, longitudinal experiences that when summed up equal the required rotation time. So again, I think they're just providing more flexibility in time requirements to set up how rotations are completed. So some other rotation changes to the experiential curriculum. The first one I thought was kind of odd is at least 4 weeks during the final year must be in a primary patient practitioner role without supervisory responsibilities. So that means you're not educating other residents, you're not educating any other medical students. So I imagine you could stipulate to that by having that in your goals and objectives for your 4th year education experience for residents, that maybe you'd have to label that on your block diagram, or maybe you'd have to give it some type of different label to highlight to the resident and to the ACGME that they're not doing any supervisory role during that time frame. Another solution might be sending them to a lower resource center. Maybe that place doesn't have as many learners that are there, other residents or other medical students where they automatically wouldn't have to be in a teaching capacity. You have to do emergency medicine each year. That's kind of no big deal, I think. Greater than 8 weeks of experience in a practice setting designated for low acuity patients, such as emergency department fast tracks or urgent care centers, and also can't be counted as the same time as the low resource ER. So that seems odd to me and also unnecessary. So if you have an emergency room setting that has a mixed experience where you're seeing low acuity patients and high acuity patients, I don't know why you would necessarily need to have designated 8 specific weeks to a designated fast track, as well as the idea of sending an emergency resident to an urgent care for 8 weeks just seems kind of bizarre to me. So I'm kind of hoping this stipulation doesn't make the final cut. But if it does, and you don't have a fast track in your emergency room, you probably would have to set one up or find urgent cares to partner with. But can't imagine that attracts residents to wanting to go to your residency to work in an urgent care. There's also an option for their rotation experiences that if you're not meeting that 120 critical care patients per resident position, you can also add on critical care experience because they realize that there's an ebb and flow to critical care numbers. So you can add on an extra ICU rotation if need be. The pediatric times proportionately similar. They want 24 weeks, which is 6 months. Previously, I think it was 5. 50% has to be in an emergency room setting, which means you can't count your numbers by adding a whole bunch of PICU rotations or NICU rotations. Some interesting stuff changed where we're required to have 2 weeks in obstetrics. That's imagined to help obtain your 10 vaginal deliveries. You have to have greater than 2 weeks of experience in admin and quality assurance, which is a big change. Greater than 2 weeks of experience in toxicology, and that I want to talk about for a second. It also includes experience in addiction medicine or substance use disorders. The toxicology aspect of it, I imagine, would be more interesting to a resident. But every state doesn't have a toxicology center. Like a poison control center, I'm at. So unless you have a specific toxicology service or somebody that rotates in that, I might have a little bit of difficulty or having that 2-week experience. I imagine you could set something up where it's 2 weeks of tox in your own hospital, where you are rounding on patients or maybe reviewing patients that have had overdoses or have been dealing with addiction with some specific reading that goes along with it. Maybe that would be easier if you're, I don't know, have a residency in the middle of Montana or something like that that doesn't have a toxicology rotation. There's now 2 weeks has to be delegated to an EMS experience. This also has to include things like disaster management, and if there's and if there's an air experience, then the resident has to be able to opt out of it, which isn't a change from before. That's the same thing. Which is a little bit of a change where they have to have a designated 2-week experience in EMS or greater than 2 weeks. So now moving on from rotations to structured experiences, and I'm just going to read this verbatim. So since this is kind of a newer concept, can be either a rotation or another identifiable experience, such as a didactic series, real or simulated time caring for patients, or the completion of focused educational materials such as reading or modules. So programs will consider knowledge and skill acquisition, the maintenance of competency, and the prevention of skill degradation as they create their curricula for that. So some of the things that you have to cop to for these structured experiences are things like interpreting diagnostic radiology and electrocardiogram. So that's something I imagine most residents are being taught anyway, but maybe you have to explain exactly how it's being taught and in what format now. Telemedicine seemed like a big change. I don't know if that's simply a didactic experience, kind of learning about it or practicing. I don't know. I haven't implemented any telemedicine into our program. Decision-making for patients with conditions that may also be treated by multidisciplinary teams, so like segment elevation MIs, strokes, traumas, airway management, including intubations, airway adjuncts, surgical airways, mechanical ventilation, non-invasive ventilatory management, and ventilatory monitoring. So I imagine if there's some type of teaching you can point to, modules, flipped classroom, special didactic time that goes along to vent management. Ophthalmological procedures are also included here: slit lamp exams, lateral canthotomy, intraocular pressure measurements, superficial foreign body removals. So these, again, are all have to be integrated into a didactic experience. I imagine where you can point to it at some, if the ACGME comes in and reviews you and says, here's where I'm doing this. Acute psychiatric emergencies, including management of agitation, de-escalation, use of documentation of physical restraints and sedation, and suicide risk and assessment, again, should be pointed to as a structured experience. Sensitivity exams, including GU exams, also have to be part of the structured experience. They have to have education regarding transfers of patients and EMTALA laws. And then this is also something new residents must have a structured experience in observation medicine. So the telemedicine and observation medicine are probably the two most interesting things that are on here, just because they're very modern education, I think, for residents. So we're already doing some education on observation medicine, not typically telemedicine so much. So that seems like curiosity about how to integrate that. There's some minor changes that they've made too. So participating sites must be less than 60 miles from the primary site. They've been talking about this for years, kind of the birth of how far a secondary center has to be for the residents. But the goal is not that you don't inconvenience the resident by sending them to these places. So if you already have an ICU, but you're sending to another ICU that's 80 miles away that has no additional educational benefit, then that's your kind of reach at that point. So it must review procedure logs rather than verify now, which doesn't need to be part of the semi-annual evaluation, which I thought was kind of odd. You probably should be reviewing this stuff twice a year, so it didn't seem like a big effort to kind of stipulate to that when you're doing a semi-annual evaluation, but sure. Address the well-being of residents, including informing them of available resources. So I think most programs were probably doing that anyway, talking about well-being, since wellness has become such a big topic probably over the last 10 years. especially with burnout rates for ER. So I imagine everyone was maintaining compliance with this anyway. So some stuff that didn't really change on any of the guidelines was any stuff about the program evaluation committee, the clinical competency committee, supervision, quality, fatigue mitigation, all pretty much stayed the same. Work hours didn't really change. They kind of just tightened up a lot of the language about it, and they put some of the examples about how to maintain work hour compliance when patients are attending didactics, that were also in the FAQs. They just kind of in the guidelines now. So that was my main takeaway from looking over the 67 pages of new ACGME guidelines. Those are my big takeaways. Other people might find other things when they read through them themselves. But the ACGME is accepting comments on this topic until May 1st. So I'll try to include a link to have any comments, because I imagine this will cause some backlash and lots of people will have feelings and thoughts about this. So thanks for watching.